Good afternoon and Jai Hind everyone. Myself, Mrs. Khushbu Rani, Assistant Professor in Pannadhaima Subhati Nursing College, and I am Alumni Coordinator in Pannadhaima Subhati Nursing College. So here we are going to present our next Alumni Speak webinar. Now today's guest, Mr. Shivakar. He is also our alumni. He did BSc Nursing from Pannadhaima Subhati Nursing College, and now he is working as a senior nursing officer at AIMS Mangalagiri, and he is the in charge of Department of Anesthesiology OT. So we are welcome from Pannadhaima Subhati Nursing College on the behalf of Principal Madam Dr. Geeta Parvanda. So Shivakar, we are welcome to you in our alumni speak. So next we are give the hand over to Mr. Shivakar. He will start the session. Thank you.
Thank you for the beautiful introduction, madam. So, myself Shivakar, Senior Nursing Officer and in charge in Department of Anesthesiology in Operation Theatre. I am working here in AIMS Mangalgiri from last 4 years. I joined here in 2019. So, as we are going to discuss today in this session regarding perioperative nursing care, first of all, before starting the session, let me take the opportunity to thank our beloved and honorable, respected Dr. Geeta Pravanda Madam, the Principal College of Nursing, and the Alumni Coordinator, Mrs. Khushbu Madam, who has given this opportunity to me to come and have a session on perioperative nursing protocol. So let's start with the session. So today we are going to discuss regarding perioperative nursing protocol inside operation theater. Yes, so basically perioperative nursing, what comes under it and what regarding the perspective of a nursing officer or a nurse, today we are going to discuss. So aims and objective of my class today, it will be, we'll discuss regarding operation theater. Then the second, we will discuss regarding introduction of perioperative care. Then what are the phases of perioperative care, roles and responsibility of pre-operative nurse, interoperative phase, then roles and responsibility of scrub nurse and circulatory nurse, which is very, very, very important from this view. Then post-operative phase, roles and responsibility of post-operative nurse. What are the common problem arise in when you are taking care of the patient in PACU and how to tackle that? That also we'll discuss today. Then the recovery and discharge criteria, when we are going to discharge the patient, how the patient is going to recover, what are the problems you are going to face with the patient in the during the care in PSU. Then we'll discuss some case scenarios also we have taken, and that scenarios which I have faced in being working as for a nursing officer in operation theater in last 4 years. So we'll discuss those case scenarios and we'll identify how to tackle those things. So we'll start next slide, please. So basically, operation theater. What is an operation theater? Actually, operation theater, it is also known as operating room. In the Western countries, we call it as operating room, and here in our India, basically we call it as operation theater. That's also called known by the name operating suite or operation suite. It is a facility within the hospital where the surgical procedures are being carried out. So surgical procedure are being carried out, but the main important thing is in a aseptic environment. So that is a point to be noted, that the surgical operation which are being carried out in operation theater should be in the aseptic environment. Yes, next slide, please. So next we are going to discuss about the zones of the OT. When we discuss about the OT, we should know about the different zones of the OT, what zones comes under the operation theater. So first one is the protective zone, that basically consists of the area outside the operation theater complex. For example, our changing rooms will come inside there, and the areas of the hospital that are called as protective zone or an outer zone, but it is a part of the OT but away outer zone of the OT. Next is the clean zone. Clean zone basically consists of the theater complex uh, under the operating room only, but it is outside the operating room. Basically, it is out of the OT complex. So it is the theater complex where, for example, our storerooms are being placed, or the instrument what we are keeping, autoclaved room also will come under clean zone. Third is sterile zone, or it is also called as aseptic zone. That is a house for the operating room where we carry out the operations and surgical procedures in the aseptic environment, that is called as sterile and aseptic zone. Last is disposable zone, that is a separate exit for contaminated linen. What linen we have used during the case, what linen we have been used during the surgery, those linen will be kept separate into the disposable zone. So used linen and instrument will be kept in disposable zone. So I hope you understand the you understood the zones of the OT. Next, moving to introduction of perioperative nursing. Basically, when we talk about perioperative nursing, it is compiles and consists of the delivery of patient, which is carried out in the three phases. First is preoperative phase, second is intraoperative phase, third is postoperative phase. Peri means combination of the nursing care which is given in preoperative phase, interoperative phase, and postoperative phase. So that is very important. It compiles of three phases of the patient care in the three units. So the nurse, what a nurse will do in the perioperative phase. So nurse has to collect the patient data. What the patient will come, patient care will come under it is organizing and prioritizing the patient data, establishing the nursing diagnosis according to the according to the patient problem, identify the desired outcome, develop and implement patient care, evaluate the care in terms of outcome which we need to achieved by the patient. So next, moving in the perioperative phase, there are three phases as I have already discussed. Next slide, please. One is preoperative, second is intraoperative, third is postoperative. Yes, next slide, please. So let's talk about preoperative phase. So preoperative phase basically begins when the surgeon decides, okay, this patient needs a surgery, either immediately or it can be planned. So it can be elective or it can be urgent surgery also. So but in preoperative phase, it will start with the decision that the surgical intervention is necessary for the patient and ends when the patient is shifted to the surgical table or OT table. Okay, so this consists of pre-operative phase. So what is, from the nursing perspective, what we have to take care of the patient, what are the points we should take into consideration during the nursing care of the patient in pre-operative phase, we are going to discuss now. Next slide, please. So how the preparation of the patient is being carried out in pre-operative area. First thing, always when you are going to do a surgical procedure, either invasive or whatever it is, any surgical procedure, it should be carried out with surgery consent or high risk consent has to be taken from the patient, has to be signed by the patient. Everything has to be explained to the patient in a understanding way, so that patient will come to know what are the procedure we are going to do, what surgery we are going to carry out in the patient. So patient should know and the consent has to be taken for the legal consideration. Second is accomplished pre-operative checklist. Checklist plays a very important role from the nursing point of view. When the patient comes to pre-operative area from the daycare ward or from the IPD or from the OPD, once the patient enters in the pre-operative ward, a nursing officer is responsible to check the pre-operative checklist. This checklist also I will display you in the next slide. So this checklist is very, very, very important from the patient point of view. Second is review NPO status. Review NPO status is very important to prevent the risk of aspiration during the surgery. So NPO, patient should be on NPO as per the requirement of the surgery or the surgeon or anesthesiologist, either 8 hours, 10 hours, 12 hours or 24 hours. That depends upon the doctor. Next is ensure bowel and bladder preparation. All those things has to be done. Enema has to be administered if it is ordered by the physician or the concerned surgeon. Next is check and inquire if any specific drug allergies is there. If the patient is having drug allergy, it should be labeled with the red color sticker, and administer preoperative medication as per the preoperative orders of the doctor. Then IVF antibiotics has to be started, IVF fluid has to be started, cannulation, all those things has to be done to secure the IV line when the patient enters to the OT table. So all those things has to be taken into consideration. Then provide clean OT dress. Separate OT dress or a uniform has to be given to the patient apart from the clothes what the patient was wearing when the patient enters the hospital. Once the patient enters to the preoperative ward, separate OT dress has to be provided to the patient. Then all those things like removing hairpins, braided long hairs, then cover hair with the cap, mask, and other things. Those things are very essential when the patient moves to the operation theater complex. Then we have to remove the dentures or the colored nail polish, hearing aid, contact lenses, jewelries which are going to interfere during the surgical procedure or intervention. Those things has to be removed, and it has to be explained to the patient seriously that this is going to play this role, why we are removing this. For example, ornaments you are asking the patient to remove, so you have to explain why we are removing the ornaments. Then the patient will cooperate with you and things will go into a smooth way. Next is checking the id band and skin preparation. All those things has to be done. Next, high risk medicine. For example, the patient is utilizing or on the regular treatment of NSAIDs or steroids or anticonvulsant or blood thinners. All those things has to be taken into consideration and has to be checked in the preoperative area only. And if the patient is on any kind of these drugs, should be intimated to the concerned surgeon or anesthetist. Yes. So next is side rails. That is very important from the point of patient safety. Side rail plays a very important role for the patient safety. Side rail should be up. All the four side rail should be up when the patient started shifting into pre-op and from pre-op to intra-op. Then patient teaching, that is very important. Actually, patient teaching should be done from the nursing officer and the concerned surgeon that this procedure is to be conducted in this way, and this may be the complications or this may be the steps of the procedure what we are going to do in the OT. Patient should come to know about it. So we have to give the proper teaching how the post-op care will be done, all those, how the recovery will be of the patient, how many days the patient has to stay in the hospital. Patient will be very anxious actually, so because when the patient is getting a surgery first time and the patient is entering into the operation theater, the patient will be having multiple doubts and multiple of questions. So those questions has to be cleared by the nursing officer and the doctor and the concerned anesthetist. Yes, please. Next slide, madam. Yes. So this is the demo of the consent form which has to be taken prior to the surgery. So patient detail will be coming into this, then provisional diagnosis, all those related data of the patient, then patient name and signature should come with the date and time. That is very important. Guardian or the relative, whoever is available with the patient, their signature will be taken before the patient move into the intra-op table. Then witness either patient relative can be play a role of a witness, or a nurse also can play the role of a witness signature. Then nursing officer signature is mandatory, and doctor signature, whoever is explaining the consent to the patient. Explaining consent to the patient is the job of doctor only, but we can play a real role as a witness to be available with the patient when the doctor is explaining the concerned surgery or the consent is being taken. So next slide, please. Yes, this is the checklist. As I have mentioned that checklist has to be checked. What are the points which will come under the checklist before sending the patient to operation theater? Word of the name of the patient has to be mentioned, age, sex, all those like basic details of the patient, bed number, IPD, then department, and the checklist will compile so 25 important points, which includes taking vital signs, ID band, height and weight measurement, general consent, high risk consent, obviously, and whether the patient is on NPO. If yes, so how many hours the patient is on NPO has to be mentioned. Part preparation if done, if not done, has to be done in the pre-op seriously, because that is going to interrupt with the like sterile procedure what we are going to conduct inside OT. Then nails has to be cut short. Then PAC, pre-anesthetic checkup has to be done. Then blood product if reserved, if the patient, if the surgery is going to be long procedure, for example, it is going to be major surgery like um, uh, laparotomy procedure which is going to take about around, which is going to cause the blood loss of around 500 ml. So those kind of surgeries we should have a blood product reserve, PRBC, FFP, whatever is asked by the surgeon or anesthetist. Then drug allergies, if any, if a patient is having any drug allergies, should be mentioned in the remark. Yes. Then pre-operative medication, if patient has taken or whatever the medication has been given, if yes given, then patient medication name and route, frequency, everything has to be mentioned. Then enema given preoperatively, jewelry removed, all the laboratory investigation if it has done or if it is not done has to be informed to the concerned doctor. Viral markers are very important to be done, and the report should be in the patient file and should be known to the concerned nursing officer, should be information to the concerned surgeon also. Viral markers are plays very important role before surgery. Then ECG, echo, chest X-ray, CT, MRI, then USG with the report, old reports if the patient is having any, then patient dress change to OT gown. So this is the checklist which has to be checked by the nursing officer, and the nursing officer has to sign with the date and name. Next slide, please, madam. So when this process of preoperative phase it is done, patient moves to the intraoperative phase. So what is intraoperative phase? Intra means inside operation table. So begins when the patient is transferred into the OT table and ends when the patient is transferred out of the OT table or OT complex. So when the patient is inside the OT complex, that phase of care comes under intraoperative phase. That is called as intraoperative phase. So what are the, from nursing point of view, what things we have to keep in mind? What a surgical team compiles of, what a circulatory nurse is going to do, what a scrub nurse is going to do, what roles we have to play for the safety of the patient, for the patient care, all those things we will discuss in intraoperative phase. Next slide, please, madam. So basically, in our surgical team, what are the our professionals? What are coming? For first is obviously our surgeon who is going to do the surgery, anesthesiologist who is going to assist the anesthetist procedure, going to give the like GA or any kind of sedation, IV sedation, GA sedation, caudal block or spinal block, regional block, whatever will be decided by the anesthesiologist in which sedation the case will be done. Then circulatory nurse, there is a very important role of a circulatory nurse inside the operation theater and in the intraoperative phase. And then scrub nurse, where it plays a very important role. Then OT technicians are there. Then support staff. Okay, these are the people and professionals who are included in surgical team. Next slide, please. Yes, the role of circulatory nurse. We are going to discuss about the role of circulatory nurse. Circulatory nurse actually plays a very important role. First role is to assure the safe patient transfer to OT. When the patient is getting transferred from preoperative phase or preoperative area to intraoperative area or into the operation theater, circulatory nurse will take the handover from the preoperative nurse and will assure that the safe patient transfer to the OT has been done. Next is assisting in positioning of the patient for surgery, ensuring the comfort and safety of the patient. It is very important, positioning. So sometimes patient will be operated under specific positioning. For example, the if the patient is undergoing any spinal surgery, the patient will be in prone position. So at that time, they have to look after the patient safety. The positioning should be done with the help of surgeon and anesthetist, when especially with the help of circulatory nurse. And they have to identify the patient, whether the correct patient has been entered into the OT. Sometime in hurry very we may miss that other patient will be transferred and other surgery should not be done. So that we have to take care that correct patient has been transferred and the same under the same surgeon only, and same procedure is being conducted inside operation theater. So verify the teaching has been received by the patient in preoperative area. That has to be verified by circulatory nurse only. Then surgical safety checklist, that is going to play a very important role, and I'm going to display you about the surgical safety checklist. Yes, please. Next slide, madam. So WHO, World Health Organization, given us surgical safety checklist. What are the points coming under it? And when the patient is into the preoperative area, into the intraoperative area, our circulatory nurse will do this surgical safety checklist before it is. First point is before induction of anesthesia, when the patient is shifted on the table and anesthesia has to be started. So we have to identify the patient, whether the correct patient has is been on the table or not. So what we have to see is, has the patient confirmed his or her identity, site, procedure, and consent? Yes or no has to be marked there, and it should be done in the presence of surgeon, anesthetist, and scrub nurse and circulatory nurse. Everyone should be present there. All the OT team should be present. Is the site is marked? Yes or no? So if it is not applicable, you have to tick not applicable. Is the anesthesia machine and medication check complete? That has to be checked. Our anesthesia workstation or the machine is working in correct way or not, that has to be checked. Then does the patient have any known allergy? If the patient is having any allergy, it has to be mentioned yes, and with which drug has to be mentioned there with the specification. Then difficult airway aspiration risk, if it is there, anesthetist will ensure whether if any difficult aspiration risk is there or not. If it is there, then you have to take yes, and equipment assistant, whether it is available or not, everything has to be marked there. Then risk of more than 500 ml blood loss has to be mentioned, or if not 500 ml blood loss, 7 ml per kg in children. The patient is our pediatric case, so there we have to check 7 ml per kg blood loss is there. If it is more than that, then we have to mention there, and we should have a reserve stock of blood product also. Next is before skin incision. When the patient is being draped on the OT table, everything is ready. Surgeon is ready to put the incision. Before the first incision, this checklist has to be confirmed from the circulatory nurse in presence of surgeon and anesthetist. Confirm all the team members have introduced by the name or role. All the, especially surgeon, anesthetist, circulatory nurse, scrub nurse, everyone will introduce themselves by their name and by their role. Okay, that has to be done. Confirm patient name, procedure, and where the incision is going to be made. This will be confirmed from the concerned surgeon. Has the antibiotic prophylaxis was being given from last 60 minutes, has to be confirmed and ensured by the circulatory nurse. Has to be confirmed from the anesthetist whether any antibiotic was given. If not given, has to be given on OT table itself. Then anticipated critical events, if any critical events has to be anticipated from both the side, from the surgeon, from the anesthetist, or from the nursing team. Every three point of thing we have to make sure that there is no anticipated critical event. If yes, we have to take in that. Then is essential imaging display. For example, CT reports are there, or X-ray reports are there, MRI reports are there, so it should be displayed on the board where the surgery is being done, which will going to help the surgeon to look after the thing, what is being the what the procedure has to be carried out inside the operation theater. So next is before patient leaves the operating room, when the surgery is being completed, everything is done, and the surgical procedure is completed, then we have to check this checklist before shifting the patient out of the operating room into the post-op area. So nurse verbally should confirm that name of the procedure, correct procedure was being done, which procedure was done has to be mentioned in the file. Then completion of the instrument, that plays a very important role. Circulatory nurse and scrub nurse both will look after and will count the instruments, if whether the before starting the case instrument and after starting the case instrument is equal or not. That instrument count should match, sponge count should match, all those things has to be checked by circulatory nurse and scrub nurse combinedly. Next is specification labeling, that will be done by identified by the scrub nurse, and the labeling and other things out of the OT will be done by circulatory nurse. To the surgeon or anesthetist and nurse, what are the key concerns for the recovery and management? If any key concerns are there, for example, if any aspiration risk is there, or the patient is having the was being estimated as difficult airway, so what are the concerns which will be taken into consideration when the patient is in PSU? All those things has to be mentioned there. Okay, so if you have any doubt, or you can ask, or this surgical safety checklist we have completed. So this plays a very important role for the safety of the patient, from the surgical point of view, inside the operation theater. Next slide please. Yes. So continuing in the role of circulatory nurse, ensure circulatory nurse has to ensure that consent form has been completed accurately or not. He has to confirm allergies and lab result. Managing the activity outside the sterile field. Inside the sterile field, my activities will be managed by scrub nurse, but outside the sterile field area, all the activities will be carried out by circulatory nurse only. Then documentation plays a very important role from the nursing point of view. Each and every activity what is being carried out inside the operation theater should be documented by circulatory nurse, each step by step. Then the nurse's notes has to be mentioned. Ensure surgical specimen are identified and placed into the right media. That is very important actually. Maintaining proper sterility. In charge of the instrument, a circulatory nurse is in charge of the instrument, counts and sharp count. After the surgery, when the counting is being done, they should check whether the count is correct or not. If it is not correct, should be intimated at the same time to the surgeon. Okay. Then relevant information to the individual outside the OTs. For example, family members are asking for any information, circulatory nurse will look after that and will convey the same information from the surgeon side or from the family members if any information has to be conveyed. Then shifting of the patient safely in PSU. PSU means post anesthetic care unit. So when the patient completes the surgery or the surgery has been done, the patient will move out of the intraoperative area to the post-operative area, or nowadays we call it as PSU, post anesthetic care unit. Proper handling of over the proper handing over, sorry, handing over proper from the intra-op. Circulatory will give proper handing over whatever things has been done, and the follow-up for the PSU, what follow-up has to be done, everything with the proper handing over should be given to the PSU nurse or the nursing officer. Next, please. Now, very important role of scrub nurse here. Scrub nurse is responsible to perform the surgical hand rub. Obviously, yes. Then setting up of the sterile trolley for the surgery. Trolley has to be set up before the when the patient moves in and before surgeon moves in. Before surgeon moves in, the trolley should be ready with each and every instrument which is going to be used during the procedure of the patient or the surgery. Assisting surgeon and surgical assistant, if any, during the operation. Maintenance of the patient safety and integrity, that is very important. Observation of the scrub team, so scrub nurse is very plays a very important role here. They have to ensure whether the sterile field is not breaked. Sterile field breaking will cause unsterile environment and can cause the risk of infection to the patient. So that has to be ensured from the scrub nurse only, whether the sterile field, no, there is no break in the sterile field. Yes, so provision of appropriate sterile instrumentation, sutures and supplies, that has to be ensured from scrub nurse. Then sharing of the share the circulatory nurse in the counting of needles, as I already informed you in the role of circulatory nurse, that this is a combined role of circulatory and scrub nurse to count the total number of instrument, and then sharps or sponges or any other instrument count what has been used during the surgery, if after the case whether those count are correct or not. Then the obtained tissue sample during surgery labeled by the scrub nurse. If any tissue sample is obtained, for example, any biopsy report has to be sent after the surgery. So those biopsy container or the what is called as or tissue sample has to be labeled by the scrub nurse. Okay, then it has to be handed over to the circulatory nurse, and circulatory nurse will hand over to the PACU nurse. Yes, next slide, please, madam. Yes, here comes we'll discuss regarding principle of surgical asepsis. When the patient is undergoing a surgery or the patient moves into the intraoperative phase, what are the principles we should know and what are the principles we should take care of for maintaining surgical asepsis inside the operation theater? So first thing is, all the materials in the contact with the wound and within the sterile field must be sterile. Yes, that is very important. Gowns are considered sterile from the front, not from the back. So that is very important point, that the gowns, surgeon gowns or the gown which is worn by the nursing officer or assistant doctor has to be considered sterile from the front only, not from the back, to the level of the sterile field, and the sleeves from 2 inches above the elbow and cuff has to be considered as sterile. Then sterile drapes are used to create a sterile field. Only the top of the drape table is considered sterile, not the bottom. Then during draping, drape is held well above the area and is placed from front to back. So items should be dispensed by the methods to preserve sterility. So that is plays a very important role during this intraoperative phase and in the principle of surgical asepsis. Movement of the surgical team are from sterile to sterile field and unsterile to unsterile field. No one should come from unsterile area to sterile area, that is going to break the chain of surgical asepsis. So that is the very important point which has to be taken care by the scrub nurse and circulatory nurse both. Next slide, please, madam. Yes, so continuing in the discussion of principle of surgical asepsis, movement around the sterile field must not cause contamination of the field. At least a foot distance from the sterile field must be maintained from any of the team member. That is very important. 1 foot distance should be maintained. Okay. Then whenever a sterile barrier is breached or broken, the area is considered contaminated. For example, you have touched any unsterile area with your gloves, so same time gloves has to be discarded and new gloves has to be worn, so that will be considered as contaminated. Then that was an example actually. Every sterile field is constantly maintained and monitored. Items of doubtful sterility are considered unsterile. Okay, the next is sterile field are prepared as close as possible to the time of use. For example, it is not like that. For example, patient was shifted in pre-op and you started maintaining and preparing the trolley, and patient gets shifted into the intra-op after preparation of trolley after 1 hour or 2 hour. So there should not be, it should not be like that. So sterile field are prepared as close as possible of time use. For example, before 15 minutes or 10 minutes you can make it ready, but not before 2 hours. Yes, next slide, please. So in the post-operative phase, what are the points we should take care of in the post-operative? What is called as post-operative phase actually? Once the surgery is being done and the patient moves out from the intraoperative area or from the intraoperative phase to the ward or post-operative area, that is called as PACU. So post-operative phase of surgical experience extend from the time the patient is transferred from the OT table to the recovery room or post-anesthetic care unit, to the moment or he or she is transported back to the IPD areas and being discharged from the hospital. That is considered complete phase is being considered as post-operative phase. So from the nursing point of view, what are the points has to be taken into consideration in post-operative phase, that is will play a very important role in recovery of the patient in post-operative phase. Actually, if we talk about which phase is very important in pre, intra and post, I will say that post-operative phase is very 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 important before, because the surgery is being done, now the patient has to recover from this. So this recovery phase is very very will play a very important role. So this post operative phase is going to be very important. Please have a patience and listen to it patiently. Next next slide please. So in the PSU, why PSU is required? Why not ward? Why cannot we shift the patient to the ward? Why cannot we shift the patient directly to the home? So why PSU is because to ensure safe and faster recovery of the patients, as the patients are still recovering from the residual effects of the anesthetic agents, and they often require assistance to the support their breathing and circulation. Then second point is it is important to assess the severity of pain, nausea and vomiting, hypothermia, bleeding, etc., and to address them, because these are certain common problems which will happen in PSU and how to assess and address them. Then third point is life-threatening complication may occur in immediate post-operative phase period, and hence vigilance is very 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 important. So that's why this PSU is required. Next is what are the PSU equipments will come under the PSU, what equipments a nurse should know their working and how to operate them. Next slide please. So PSU equipments compiles of multi-para monitors. Multi-para monitors mean these monitors should be capable of displaying ECG, NIBP, SpO2, EtCO2, invasive monitoring like IBP monitoring, invasive BP monitoring. That monitor should be capable of. Then temperature. So all this monitoring after the intraoperative phase when the patient moves into the PSU. So this monitoring has to be done. So this multi-para monitor should be ready. Then IV stands and infusion pump should be available in PSU. Equipments to manage and secure airway. Airway plays a very important role, and that is the priority of a nursing officer, obviously, and every healthcare worker. Or to backup cylinders should be there, because if any cases of any airway disturbance is coming or any like airway is blocked, that time to preserve the airway and give a proper oxygenation to the patient, O2 backup is required. Sometimes central supply may be interrupted, so that time O2 backup cylinders will be helpful. Then suction apparatus, defibrillators, crash cart, and emergency drug trays. Next, please. So I will display you what is the multipara monitor, IV stands, infusion pump, all those. So this is our multipara monitor, which is displaying the first is pulse rate, then SpO2, then we are getting the reading of BP, which is 120 by 80. So this is called as multipara monitor. Next is IV stand and infusion pump. So in left side this is our IV stand, and in right side this is our infusion pump. Next slide, please. Then equipment to manage and secure airway, especially laryngoscope plays a very important role. It should be ready, and we should continuously keep checking the working status of all the equipment. That is very important from the point of PSU nurse, because sometime in the emergency when we take the laryngoscope from the box, we will see that the blade is not working, the bulb is not working, it is not connecting properly, it is got rusted because we are not using that from long. So these things every day has to be checked, and inventory should be done, and it should be checked whether the working status of the equipment is correct or not. So laryngoscope is required, ET tubes are required, and other airway related items or equipment should be available. Next, O2 backup cylinders. Yes. So this is our O2 cylinder, how it looks like, white top and black body. Next. So this is our portable suction machine. So we have to keep checking the working status of the machine, and the pressure also we have to check. Normal pressure in adult, how much it is we should know. Then in pediatric how much it is. Then in newborn how much it is. So everything should be aware of the a nurse should be aware of all the items working. Okay, and all the equipment which are coming under PSU equipment. Next is defibrillator, please. Yes. So this is our defibrillator. We have to check the pedal and we have to check the current working status every day. The checking of the defibrillator should be done. Okay. And if you have any doubt, you can contact your in charge, and it should be, but it should be checked every shift also. Next, crash cart, and this is our emergency trolley. A, B, C, D, E, F. These are the like drawers which we used to keep items, and with the color coding we are keeping the drugs in this, and other equipment like defibrillator sometime will be kept on the crash cart, which will be helpful when the patient crashes into the PACU. It will be helpful to get the recovery of the patient. Next, please. Next slide. Yes. So basic skills. What a PSU nurse should have, the basic skills. First is airway management skill. The nursing officer should be capable of managing the airway. Then BLS, basic life support, actually cardiac life support. The nursing officer should be capable of and should have a certificate of it. And caring for the acute surgical wounds. They should know the caring for different type of catheters. They should know the good communication skill which are going to helpful for giving, taking handover and giving handover, and communicating the patient related activities to the surgeon or anesthetist. Next is attending regular CNEs and PSU related topics. So these are the basic skills which are required by a PSU nurse to work in PSU. Next slide, please. So, being a PSU nurse, very important is taking handover. When you take handover from the intraoperative nurse, what points you will take into consideration? What are the point you are going to focus more? So, first is details of the patient should be checked correctly with the patient file. Then comorbidity, allergy, and contraindications. If any drug is there is any contraindication or comorbidities or allergy, it should be checked and noted in the file and should be taken into consideration during handing over. Then details of the anesthesia, surgical procedure, type of anesthesia which was done. For example, the patient is under, the surgery was done under GA or regional block, spinal block, or any other kind of blocks. The surgery was done, so you have to check which type of anesthesia the case was done and which surgical procedure has been done. Then what are the drugs has been administered in and intraoperatively, those things has to be taken into consideration and has to be taken for a note during handing over. Then urine output, how much was the urine output in the preoperative phase, intraoperative phase, and right now in the postoperative phase, how, if any urine is there in the bag. So you have to check the amount of urine, how much was there when you taken handing over, and when you give handing over to the next shift people, that also has to be given in the proper handing over about intake and output. Then any required investigation, if any required investigation has to be done or has been advised from the surgeon during the intraoperative phase, so that has to be taken into consideration by PSU nurse. Next slide, please. The plan of action has to be made by the nurse, what, how they are going to take care of the patient in the post-operative phase. The plan of action has to be made by the nursing officer. So next is why, how we will do the monitoring of the patient. So first thing is oxygenation, peripheral auto saturation, pulse oximetry we have to do. Then respiration, in the respiration phase, what we have to check is patency of the airway, whether the airway is patent. If any blockage is there, should be reported as soon as possible to the concerned anesthetist. Then respiratory rate or capnography, if there is any irregular rate, should be informed to the concerned surgeon and anesthetist. Then circulation, you have to check heart rate, blood pressure, ECG monitoring should be done. Then level of consciousness, so you can check with the GCS scale or altered scale also, you can check the level of consciousness. Then responding to the verbal command, orientation, GCS, as I told, eye, verbal or motor reflexes can be checked in the GCS scale. So these are the scale which can be used for to check the level of consciousness. Next is temperature. Very important is core body temperature should be checked in post-operative patient. You should not believe on the surface temperature. Core body temperature should be checked either by the tympanic membrane or by rectal route or by nasal route also can be checked by for the core body temperature. Then peripheral temperature also can be checked by skin and axilla. Next. So in the continuing in the monitoring, very important is assessment of pain. So when the patient is in the recovery phase in post-operative area, so it is very important to check the pain, how much pain patient is having. Sometimes patient will not be able to explain you how much severity of the pain is there. So you can check with the VES scale or NRS scale. So these are the scales which can be used to check the to check or to assess the status of the pain, and you can carry forward that, and you can check the after giving any intervention. Then again you have to check what is the recovery of the pain now the patient is having. Next is hydration status. It is very important. Input and output charting has to be done. Early intake and output charting has to be done. Then local care inspection of the surgical site. That is very important. If there is any signs of bleeding, or you have to check for evisceration and dehiscence. That is very important. If any chance of dehiscence is there, you should know, you should check for evisceration also. And if you feel any sign of evisceration, should be reported immediately to the surgeon. So for the local care, inspection of surgical site is very important. Then prophylaxis for the DVT pump you can use, or fluotrons you can use, or DVT stockings also can be used for that. Then you may be asked to get a blood investigation, arterial blood gas, ABG also can be done during the post-operative monitoring. Then blood glucose, ECG, X-rays, all those are the regular investigation which are carrying out in the post-operative phase. Next slide, please. So when the patient is recovering in the recovery phase or in the PACU unit, there are two phases of recovery actually. So first one is immediate recovery. Second one is less frequent. For example, in the when we are discussing about phase one, so it comprises of immediate recovery of the patient requiring intensive nursing care and close monitoring. Phase one is very important in this recovery phase. Then in this phase, vital signs recording should be done every 15 minutes. Okay. Then in the phase two, that is very less frequent observation when the patient has been recovered from the depth of anesthesia and patient is out now, and the patient is able to like uh, patient is not having any pain, and now patient is recovering and moving into phase two. That time very less frequent observation is required, and vital signs documentation can be individualized. Okay. So next slide, please. So these are the two phases of recovery, phase one and phase two. Then what are the consideration for general anesthesia case and spinal anesthesia case or the local anesthesia case? That also I will discuss about you, because there are different consideration for different anesthesia. So for example, the patient was done under general anesthesia, the case was done under general anesthesia surgery. So general anesthesia, now in the first point, administer supplemental oxygen as desired. So what is the effect of general anesthesia actually? So general anesthesia, after when the patient is surgery has been done under GA, so in GA all the smooth muscles and the skeletal muscles will be collapsed, will be paralyzed or relaxed. That time when the patient is being given reversal drug also, now patient is in PSU but is recovering slowly. So that time supplemental oxygen can be required, because skeletal muscles are not playing the role as 100%. That's why head should be up by 30 to 45 degree, then hemodynamically stable, then supine with the head supported by pillow, neutral position or turn to one side position should be used. Lateral position also can be used for the pediatric patient or tonsillectomy cases, adenoidectomy cases, or airway obstruction cases. Why? Because when the patient is in the lateral position, airway is more patent. Then care of the pressure areas, that has to be done to prevent the chances of bed sores. Then DVT pump, forced air warmer can be required. Why? Because after the general anesthesia, when the patient is in the recovery phase, will have the chances of chills, where patient will feel chills and shivering. So for to tackle that, you can use the forced air warmers and DVT pumps. Next is care of arterial and CVP lines. That is very important. Foley's catheters, because all the muscles are not playing their role at the best. So that's why you can be needing the Foley's catheters, because our bladder muscles are relaxed. And chest and surgical drains, epidural and peripheral nerve catheters can be used for the these points has to be taken into consideration after general anesthesia. Next slide, please. So, what are the consideration for neuroaxial and regional anesthesia? For example, the patient was done under spinal. When the spinal anesthesia has been given to the patient, so it will act on particular site. For example, any regional anesthesia has been given, or we'll take an example of spinal anesthesia, that will act only on our lower extremities. Our upper extremities will be in the senses, but our lower extremity will be out of the senses. So that time care of the lower limbs should be done very important. and blocked limb, if any no sensation is there in any part of the body or any limb of the body. So we have to check the motor power also, and according to that only the care of the concerned limb has to be done. Okay, next is care of the pressure areas. Movement, getting out of the bed, assistance will be required by the patient because their lower extremity is not functional adequately. Then voiding of the urine, for that also, because bladder muscles are relaxed, for that they will need an assistant, or you can be using the Foley's catheter for that. Then hypothermia will be there. Then care of the epidural and peripheral nerve catheters, for that you should see for avoiding misconnections. You should know how to work for epidural catheters if there, if it is placed, or if the patient needs any caudal for the caudal block, if they needs any additional drug, for that how to give that drug. All those things should be taken into consideration when you care for the patient for regional anesthesia and neuroaxial anesthesia. Then very important point which every nursing officer or any healthcare person will have a doubt, like whether it is good to use pillow after spinal anesthesia. So one research was done on this. Can we have next slide, please? I will show you that. So this was the research which was done. Occurrence of headache with and without pillow cushion in spine and after spinal anesthesia. So that was the research done by Department of Anesthesiology, Kathmandu Model Hospital, Kathmandu in Nepal. It was published on March 5th of 2017. So you can read the conclusion of this research is supine position with the pillow cushion in the immediate post spinal period caused a non-significant decrease in the incidence of headache and a significant increase in the comfort. And this study could not conclude whether a pillow cushion affects the occurrence of PDPH, and as there were no cases of PDPH in either group. What is PDPH? Is post-dural puncture headache. So when you puncture the dural space or after the spinal anesthesia, there is no risk of placing the patient in supine position with the pillow. There will not be any occurrence of headache. So this was the research which was published by the Department of Anesthesiology of the Kathmandu Hospital. So this you can take into consideration, and the pillows can be used for the post-operative case if it is done under spinal anesthesia for the comfort and safety of the patient. Next. So what are the common problems what arises in the PSU? First is very important is upper airway obstruction. For example, the patient was being operated under GA. So in that patient, when the patient is recovering in the PSU unit, will have tongue fall issues and problems. So with the tongue fall, that can obstruct the airway. So in that upper airway obstruction, patient will move into the desaturation. So that is very important. You have to monitor for the obstruction of the airway continuously. Second is hypoxemia, hypertension, pain, nausea and vomiting, shivering. These are the common problems. But in this, very important is upper airway obstruction. For that, I will discuss somewhat in detail. Next slide, please. Yes, so upper airway obstruction, why it will lead or why it will happen. Loss of, because of the loss of muscle tone, residual effect of anesthetic agents, NMB, neuromuscular block. NMB means neuromuscular block. So because of this block or effect of anesthesia, there will be loss of muscle tone. Because of this loss of muscle tone, tongue may fall back. When the tongue fall back, it may obstruct the airway. Once the airway is obstructed, patient will not be able to breathe and the saturation will be desaturated. So this is very serious and a very important point to remember, that upper airway obstruction has to be monitored very seriously. So you have to take care of this upper airway. How you can take care, I will discuss. Next slide, please. You can use the oral airways or nasopharyngeal airways, or you can maintain the patency of the airways with that. Like you can use that jaw thrust maneuver also. For example, first point, how to manage the airway obstruction. Maintain patency of airway. How? Clear patient's airway. Then supplemental oxygen can be done. Bag and mask ventilation can be done. Use of airway adjuvant. For example, oral Goodall airway can be used, nasopharyngeal airways can be used, and positioning plays a very important role. So patient can be placed into the lateral position, that will prevent the fall of tongue. Then next slide, please. So this is how you can manage the upper airway obstruction. These are the some oxygen delivery devices what you use commonly in your hospital. First one is nasal prong, second is our O2 mask, then NRBM, then in the left side down it is our Venturi mask, then our back and mask ventilation, then this is our vein circuit. So these are the oxygen delivery devices which are used to deliver oxygen to the patient. Okay, in PSU or other areas of the hospital. So this is the example of airway adjuvant. What is oral pharyngeal airway looks like, how nasopharyngeal airways looks like. So how this you can see in this in the picture, the patient is made into the rose position, and now this airway has been installed, inserted into the oral cavity. So this airway is going to play a role to insert for the entry of the air to the airway. So if the airway has been blocked, you can use oropharyngeal airways or nasopharyngeal airways. The next slide, please. How to use that also I have mentioned. Second is assessment of pain. As I have mentioned, that pain can be assessed with a different scale. First scale is visual analog scale. So with this, by seeing the patient only, you can see what severity of the pain patient is having. We can categorize from 1 to 10 rate also. Then second is NRS, that is numerical rating scale. Third is verbal rating scale. Last one is FLAC rating scale. This is done for the pediatric cases, FLAC. So these are the some common examples or type of skills which can be used to identify or assessment to assess the pain severity. And according to the pain severity, only the intervention can be given to the patient. Next slide, please, madam. Yes, so as I have mentioned, that pain management, how the pain management will be done. So review of the patient's anesthetist chart. What anesthetic drug was used in the intraoperative phase, that we have will see what analgesic was administered intraoperatively. For example, the patient was given intraoperatively some like painkiller drugs. For example, tramadol was given, paracetamol was given, or steroid drugs was given, and NSAIDs was given. So in a post-operative phase, what frequency that drug can be used, that we have to discuss with the anesthetist first. Then only we should administer the concerned drug. So some of the common examples of the drug are here. Opioids can be used for the pain management, that plays a very important role in post-operative care unit. Second is non-opioid adjuvants. NSAIDs can be used, paracetamol can be used, very common drug. Then epidural PNB catheters, LA infusion, local anesthesia infusion can be used. Patient control anesthetic drugs can be used, or PCA pump. PCA means patient controlled anesthesia. This is a kind of an object or machine which is used by the patient to control anesthesia. There is a button in this machine. When you press the button, the drug will be administered to the patient directly without the assistance of the nursing officer or the doctor. So this device can be managed by the patient. It is called as patient controlled anesthesia machine. So opioids can be administered with this machine. Next is single shot of peripheral nerve block can be given if any specific part of the body patient is having any pain in specific part of the body. So single shot peripheral nerve blocks can be given by anesthetist. Next slide, please, for the pain management. So what is PONV? This is a post-operative nausea and vomiting management. That is very important, and it makes patient very anxious and irritable when the patient is in PSU. Because of the GA also, it may happen in some particular patients. So from the nursing point of view, what things we have to make sure, things we have to take into consideration for PONV management. First thing is measure the patient blood pressure at like regular interval. Every 15 minutes to 30 minutes, the patient blood pressure has to be measured. If the patient is having hypotension, there are chances to get a nausea and vomiting. Then assess hydration status of the patient also. You can ask the patient, do you feel thirsty? So all those things can be done to assess the hydration level. Then third is give IV fluid boluses. If the patient is having nausea, vomiting, so IV fluid boluses has to be given as per doctor's order. Then keep kidney tray ready. Suction apparatus should be ready. Why? Because you should prevent the risk of aspiration. When the patient is was case was done under GA, the patient will not have the muscle tone. So because of the loss of muscle tone, risk of aspiration increases. Once the risk of aspiration increases, aspiration is very critical event during the care of patient in PSU. So you should make sure the kidney tray is placed there and the suction apparatus is ready to have the suction and to prevent the chances of aspiration. Then review patient's anesthetic chart. what antiemetics was given, or if it is what it if or if it was not given in intraoperatively, you can administer in postoperatively. For example, MSETs or metaclopramide, these are the common examples of the drug antiemetics what we are using for the patient. 5-HT3 antagonists, steroids, prokinetics, antipsychotics, anticholinergics, antihistamines. This depends upon the patient category, and on the doctor's orders you should administer them. So this is the management of nausea and vomiting what you can do in the PSU. Next slide, please, madam. So very common problem what the patient is having for shivering, because when the patient is recovering from the depth of anesthesia, from the effect of anesthesia, patient may feel shivering. So what are the, how you can manage being a nursing officer about shivering? So first point is measure patient's core body temperature. You should check the temperature, whether the patient is in hypothermia or not. So that has to be checked. Then forced air warmer can be used with the maintaining the temperature. For example, the patient warmer can be used by putting the temperature at 40 degrees or 45 degrees based upon the patient priorities. Then administering of the supplemental oxygen, administering warm IV fluids can be done, hotline. Then blankets and cotonol can be provided to the patient. Pharmacological management can be done. Pethidine, tramadol plays a very important role for shivering management. Next, please. So now the very important question is when to shift the patient from PSU. Patient is in PSU, everything has been managed. We have discussed about the managing patient with the different problems. Now all the problems have been managed, but now the question in the nursing officer's mind is when to shift the patient from PSU. So this will be decided in on basis of the these points. So first thing is CNS, central nervous system. What we have to check is consciousness of the patient, whether the patient is conscious, fully conscious, oriented, fully oriented or not, oriented to time, place and person, awakening, then responding to oral commands. When these things are being matched and the patient has been recovered with from the CNS, so this is the first point and very important point you should check for shifting the patient from PSU to ward. Then CVS, hemodynamical stable status of the patient has to be checked. Then that will be checked by good blood pressure. The patient is having normal blood pressure from last 1 or 2 hours. You can check, okay, CVS patient is hemodynamically stable, and we can shift the patient from PSU. Next is in the respiratory system, what we can check is whether the patient is maintaining oxygen saturation or not. Target oxygen saturation is always 95 to 100 degrees on room air, or 95 to 100% on room air. So that has to be maintained. If the patient is maintaining that, you can think, okay, now the patient is fit for shifting from PSU. Next is good cuff reflex. If it is coming, then completely recovered from neuromuscular block. If the good cuff reflex is coming, so now you can think that patient has been recovered from neuromuscular block. Fourth point is temperature. Normothermic with the warm peripheries. This you have to check continuous monitoring of the temperature. When the patient is normothermic, means the patient is having normal temperature, that time we can shift the patient. Then pain, nausea and vomiting, as I have already discussed about the management of pain also, nausea and vomiting also. So when these three things are being well controlled, that time you can shift the patient from PSU. Now you can see that patient is recovering well. Then if when the patient is able to mobilize and pass urine by its own, and then take oral liquids as desired. So these are the some points which has to be taken into consideration, and should be kept on the priority before shifting the patient from PSU. Okay, so this is the criteria. Next, please. So when you are shifting the patient from PSU, how the handing over has to be given to the concerned nursing officer or your colleague in the HD or ICU or to the new ward. How the handing over will be given? Patient may be go back to the parent ward or to the new ward as HDU or ICU. Details of the patient, comorbidities, allergies has to be communicated to the concerned nursing officer. Details of anesthesia and surgical procedure has to be communicated and conveyed to the concerned nursing officer to whom you are giving handing over. Next is urine output, and third for fourth point is course of the event when the patient was in PSU. For example, we have discussed regarding pain management, nausea and vomiting management, and other points also, airway management. If any such incidents have happened in PSU and you have tackled them, now patient has been recovered, but it should be communicated to the concerned ward and nursing officer also that this was happened and we have managed the patient in this way. Everything should be documented with each and every step, and should be communicated to the next duty handover or to the ward ward nursing officer during handing over. The course of the events has to be discussed well. Next point is investigation performed. What are the investigation the doctor have been performed, or we have sent any samples or to the lab, or the reports are pending? Everything has to be communicated to the ward nursing officer. Next is plan of action. What is the plan of action right now when we are shifting the patient from PSU to the ward? When to start the feed? That is very important. Or thromboprophylaxis, whether it has to be continued to the ward or not. Then fluid management, how frequently we are going to give the fluid to the patient. Then analgesia, whether we are going to use any analgesia in IPD area or not in the ward. So all those proper handing over should be given as it is ordered by the concerned doctor or anesthetist. So these are the certain points you have to take into consideration during giving and handing over from PSU to the ward nursing officer. So we'll discuss about the key points. What key points we will see when the patient is in PSU? So these are very important. Please have a look. It is specifically designed by, because PSU is specifically designed well equipped unit wherein the patient of all age groups, starting from the pediatric to the elderly, recovering from anesthesia, are monitored closely by specially trained staff. So you know well that because we have checked everything, skill qualities also, how a PSU nurse should be there, and how what qualities a PSU nurse should have. So this is a very specially designed area, well equipped area, where the patients are recovering from child age to the elderly age. So this recovering from anesthesia has to be monitored closely by the specially trained staff. That is a very key point to note. Then they should know how to manage the common problems arising in PSU. With regarding common problems, we have discussed that upper airway obstruction, then pain, nausea, vomiting. These are the common problems what the patient will have in PSU, shivering. So these are the key points you should note. Okay, then face a fast-paced environment, be alert and ahead of time. For example, you have noticed that the patient is anxious, you have noticed the patient is getting angry, or you have noticed that there is some change in the patient mood or attitude and attire. So you can check what the next step is going to happen. For example, the patient is having high BP, or the patient is having shivering, or what next role the patient will have. So our nursing officer or our well trained staff should be ready for the next step. So that is very important. So the PSU nursing officer, whoever is working there, they should have a good communication skill, which is going to help them during the case of emergency or handing over of the patient from the intra-op to the PSU and from PSU to the ward area. Then documentation is equally very important. As I have mentioned in the intro also, that each and every step has to be documented, how the operation was done and which drug was used. And same thing in the PSU also, if any common problem have arrived and you have tackled that also, but it should be documented properly. Whether any lab investigation has been sent, report is pending, whatever from the nursing side or from the patient point of view, if anything, any activity has been performed, has to be mentioned in the nurse's notes, and documentation is equally very important. Next point, please. So in the key point, we have seen the main special points. Now the area is specially designed, area is specially uh, located, then specially staffed, then specially equipped. So there is a specific purpose of patient care. So this I want to convey, that these are the key points, and where PSU area is very very important during the peri-operative nursing care. Next, please. So, if any questions are there, you can text me, or you can ask from, you can convey to the Khushbu madam, and madam will convey to me, or you can message me directly also. You can get my contact number from madam, or whatever the question if you have in this session, you can ask me. Okay, you are free to ask.
Thank you, Shivakar. It's a very informative session.
Yes, ma'am.
Actually, it's a most informative session. Most of the students didn't know about the operation theater, these all the protocols. Even
Yes, ma'am.
previously, most of the things I also didn't know. I also gained something. Thank you so
Yes, ma'am.
much. So, participants, if you have any doubts, you can write in chat box. We will
Yes,
give
ma'am.
your answer, or we will clear your doubts. You
Ma'am, one
can
more
write in
slide is
chat
pending
box.
for me actually.
You will see afterward. We will see afterwards. Then we will give your answer if you have any doubts.
Yes, ma'am.
So now I would like to thank you, Shivakar, for this session and giving your very precious time to give the
Yes,
present this webinar. Actually, as a
yes,
alumni coordinator, we will arrange every month.
yes,
So
ma'am.
next month also we will arrange some another alumni, so you please join us. Then
Yes, ma'am.
now I would like to thank to Principal Madam, those who gave me this opportunity and give the opportunity to attend and organize this webinar every month as a alumni. So and I would like to thank to most important part of this webinar, our participants. These are
Yes, ma'am.
these they are also attended this webinar. So in it's a most proud moment that this is the first webinar in that most of the participant attend this webinar. Previously, 4 5 participant was there. Afterwards, they will see. Then in that webinar, live 15 participants are live till now, which
Yes,
I
ma'am.
am seeing here. So most of the participant, I think, know to you. They write in chat box, "Hello, sir. Good afternoon, sir." So, so okay. Thank you, participants, to attend this webinar. Thank you, Shivakar. Then we will meet next month.
Sure, ma'am. Sure, I'm sure.
For another element.
Okay,
Thank
ma'am.
you.
Thank you.